doctors. So going to continue with our Mrcp consultation station, and today I'm going to talk a bit about multiple myeloma. So let's start with our presentation. So as usual, we are talking about the consultation station. So I'd like to talk about the history first. So this is a 62-year-old male and he presents to the hospital emergency department with nausea, muscle cramping, and reduced urine output. He reports feeling fatigued and have lost weight over the past 6 months, but exact history is difficult due to confusion. Now, remember that multiple myeloma is actually a disease of the older adults with peak incidence between the ages of 60 and 70 years, and less than 2% will be diagnosed before the age of 40. Myeloma is slightly more common in men than women. It's twice as common in those of African origin compared to the Caucasian or Asians. Now, this patient has presented with reduced urine output. If the patient gives history of reduced urine output, these are the symptoms of renal failure. And nausea, patient also having nausea is likely to be due to uremia, which can also lead to anorexia, vomiting, and altered mental status. Muscle cramps, well, these are symptoms of hyperphosphatemia and hyperkalemia of renal failure. So reduced urine output is concerning for oliguric renal failure due to multiple myeloma. So fatigue, it can be because of the anemia from bone marrow infiltration, or it may also be due to underlying disease process or from slowly progressing undiagnosed renal failure. Weight loss is due to the hypermetabolic activity of the disease process. This often occurs gradually and may not be noted by the patient. So remember, in the history, if the patient is unable to quantify the weight loss, ask whether their clothes feel loose or whether they are tightened, their belt recently. Ask family or friends present if they have noted weight loss, and pay attention to loose skin folds on examination. So remember, there are a number of metabolic abnormalities which could contribute to confusion, including uremia, hypercalcemia of myeloma, anemia, and hypoglycemia due to accumulation of oral hypoglycemics in renal failure. Okay, let's move on to our history. So medical history is significant for type 2 diabetes, for which she takes an oral hypoglycemic medication. So multiple myeloma is actually a neoplasm. It's caused by the accumulation of abnormal plasma cells in the bone marrow. It is thought to develop over a period of time, and almost all cases they originate from percutaneous monoclonal gammopathy of unknown significance called MGUS. And this patient, well, they may have had myeloma for many months and has only presented acutely with symptoms of renal failure. So the patients may have a background nephropathy due to his type 2 diabetes. Previous renal function testing should be sought from the local GP. The background history of diabetes is significant in malignancies such as multiple myeloma, as a large part of treatment involves intermittent high dose of oral corticosteroids, and this can cause difficulties in glycemic control. Moving on, he also been taking regular paracetamol and NSAID for new lumbar back pain. So the use of an NSAID to control the back pain is likely to be further contributing to the renal failure. The acute tubular damage and necrosis, which is produced by the combination of dehydration, hypercalcemia, and abnormal protein deposition, it is exacerbated by the use of NSAIDs. Back pain is reported to be one of the most common symptoms in patients with new diagnosis of multiple myeloma. It's occurring in about 70%. This may be due to undiagnosed lytic lesions or crush fractures, or maybe due to bone marrow infiltration. The abnormal plasma cells, well, they can secrete factors which activate osteoclasts. This results in bone breakdown leading to lytic lesions, hypercalcemia and bone pain. It is noted he has 2 chest infections this winter, which is unusual for him. Now remember, infections occur in multiple myeloma patients due to reduced functional immunoglobulins, and this is called immunoparesis. So those with hypogammaglobulinemias are more susceptible to infection with encapsulated bacterial organisms, and the absence of antibodies results in decreased response to polysaccharide antigens such as in the bacterial cell wall, so leading to limited ability to phagocytose and kill the bacteria. There is no history of abnormal bleeding. Important negative to rule out, because thrombocytopenia is usually only seen in advanced disease and may contribute to bleeding. However, the myeloma paraproteins, they can interfere with platelet functions and coagulation factors in the absence of thrombocytopenia, and consequently they can cause bleeding and bruising. And another important thing is uremia. It also can lead to platelet dysfunction and increased bleeding. Past medical history we have to ask about. In this patient, the surgical history is significant for recent carpal tunnel release. Now, carpal tunnel syndrome is relatively commonly seen in the general population. However, in patients with multiple myeloma, the history is concerning for a complication of myeloma called secondary amyloidosis. So ask about other symptoms of peripheral neuropathy or cardiac failure, as amyloidosis can affect the peripheral nerves and cardiac function. So this is all about the history. Let's move on to the examination of this patient. So the patient looks unwell and is hypertensive and tachycardic. Obviously the blood pressure, you can take the blood pressure or you can ask the examiner. There is pallor to the palmar creases, but no bruising is seen on the limbs. Important negative to rule out. So pallor is likely due to anemia. In some patients, anemia may be the initial clue to the underlying bone marrow disorder. This patient may have been anemic for months prior to presenting acutely. Bruising, well, it is important negative to rule out, may occur due to coagulopathy or abnormal platelet function, which can occur in myeloma or uremia. Bruising is also rarely a sign of hyperviscosity syndrome, which can occur with high paraprotein levels. So there is pallor to the palmar creases, but no bruising seen on the limbs. Asterixis is not present, and there is no macroglossia. Now, asterixis may be present in those with uremia. So we know that how to elicit it is elicited by asking the patient to flex their hands back towards their face in an outstretched position. Upon holding this position for at least 20 seconds, a jerky flapping tremor may be noted. A similar sign can be elicited in those with hypercapnia. Now, important negative in this patient has no macroglossia. Macroglossia refers to the presence of a large thickened tongue, which would be concerning for the presence of amyloidosis, and this occurs due to extracellular deposition of fibrillar insoluble proteins. Okay, JVP is elevated in this patient. So the elevation of JVP is a sign of fluid overload. So chest should be examined for crepitations and the lower limb for peripheral edema. And fluid overload may be noted by the patients around the abdomen or in the face. The chest is cleared to auscultation, and cardiovascular examination reveals tachycardia with no other abnormalities. So examine the chest to elicit signs of fluid overload and infection, which can occur due to immunoparesis or multiple myeloma. A pleural frictional rub is associated with uremia. Now, the findings on cardiovascular examination may include a pericardial friction rub due to anemia, maybe signs of fluid overload due to renal failure, or signs of cardiac failure due to amyloidosis. And we all know that these signs include raised GVP, displays apex beat due to cardiomegaly, and maybe some added heart sounds or a systolic murmur. No lymphadenopathy is appreciated. Uncommonly, multiple myeloma can cause lymphadenopathy due to infiltration of lymph nodes. More commonly, lymphadenopathy in the context of plasma cell disorder is due to lymphoproliferative disorder, such as lymphoplasmacytic lymphoma. It's also called Waldenstrom's macroglobulinemia or a plasmablastic lymphoma. Now, these may have overlap with myeloma but have different treatment strategies. Palpation of the thoracolumbar spine revealed tenderness between L3 and L5. So bony palpable bony tenderness may be elicited in patients with crush fractures or plasmacytomas of myeloma. So gently press the fist against each vertebra if possible, assessing the patient reaction to the movement. Palpation, okay, so remember that if we are suspecting myeloma, remember to palpate the spine. And urine dipstick will obviously ask the patient to do the urine dipsticks, and this patient, it reveals protein. So proteinuria, albuminuria, or nephrotic syndrome can occur due to a number of causes in myeloma, including like amyloidosis, paraprotein deposition, membranoproliferative glomerulonephritis, and these all can occur in response to the paraprotein. So remember these salient points in the examination. Let's talk a bit about the investigations. So full blood count demonstrates a normochromic normocytic anemia with mild neutrophilia and normal platelet count. The blood film shows red cell Role. Now the anemia is due to decreased red cell production in infiltrated bone marrow. The abnormal plasma cells crowd the bone marrow, halting the production of normal blood cells, and then anemia is usually normocytic or macrocytic. So remember that myeloma screen should be performed in patient presenting with an unexplained macrocytosis. Mild neutrophilia may be reactive due to patient being unwell and due to dehydration of acute renal failure. The patient could also be presenting with infections in the context of being immunosuppressed due to malignancy. While in advanced disease, you may see neutropenia as well. So red cell Rolex, these refers to stacking of the red blood cell, and you can see in the peripheral blood film there is a stacking of red blood cells, and this can reflect an increase in plasma fibrinogen, immunoglobulin, or proteins in the blood, and it is associated with an increased ESR by definition. And but remember, they are not specific for myeloma. These can occur in infection and in other malignancies as well. So there are no blast or plasma cell scenes in the peripheral blood film. So remember that patients with multiple myeloma will not have blasts in the circulation, as this is not a myeloid condition. So malignant plasma cells of myeloma, they are a mature hematological cells, whereas blasts are very immature form. In rare cases, patient can present with plasma cells in the peripheral blood. This is very abnormal and is referred to as plasma cell leukemia. It presents with the features of both acute leukemia and multiple myeloma. And despite the systemic chemotherapy, it has a very poor prognosis. ESR is markedly elevated, and we expect the ESR to be high. Urea electrolyte shows elevated urea and a markedly elevated creatinine level. So the ESR actually is a measure of rate of red cell falling, or we call sedimenting in a tube in 1 hour. A very high ESR suggests serious infection. autoimmune conditions or malignancy. In myeloma, the ESR is raised due to the presence of serum paraprotein causing increased plasma viscosity. Elevated urea, and we know that elevated creatinine suggests that the patient is in renal failure. This may be due to dehydration or hypercalcemia. It may also be directly due to myeloma, and there are two main mechanisms for this. The serum free light chains, they can deposit in the kidney and causes mechanical obstruction, and this is referred to as cast nephropathy and myeloma kidney. And less commonly, the patient may have secondary amyloidosis. And we know that amyloidosis, there is an abnormal protein which can deposit in the renal tissue, so causing nephropathy, including nephrotic syndrome. So estimated GFR rate is also low. Corrected calcium is markedly elevated, and serum calcium, well, it is increased in some patients due to resorption of bones. Serum calcium must be measured upon suspicion of a plasma cell disorder. Evidence of hypercalcemia indicates tissue damage and is an indication for treatment of symptomatic myeloma. Okay, so albumin is below the normal range. However, the patient total protein is elevated. So remember that low serum albumin, it can be a sign of advanced disease, and albumin is a key prognostic factor and is used in scoring systems to calculate staging and diagnosis. The patient is presenting with a protein albumin gap. So in the serum, there are many types of proteins which are present in small amounts with different functions. Albumin is one protein that is commonly able to be measured on laboratory tests and make up a large proportion of proteins in the serum. So when there is a large gap between the amount of total protein and the major protein albumin, it is suspected that an abnormal paraprotein is making up the difference. All right, so beta 2 microglobulin and LDH are elevated. Now we have to do these, look for these beta 2 microglobulin, because beta 2 microglobulin is actually is a molecule that sits on the surface of lymphocytes and plasma cells. So as it is excreted by the kidney, it is also elevated in renal failure. It is used as a prognostic marker, reflecting the presence of large number of plasma cells. A paraprotein is a monoclonal immunoglobulin which is produced by the malignant plasma cells, and the abnormal plasma cells produce paraproteins which are abnormal immunoglobulin light chains, and the paraproteins is also referred to as M proteins. So as you can see in this, this IgG kappa paraprotein of 42 with markedly elevated kappa free light chains, but normal lambda free light chains. Okay, so these are all the paraproteins which you should look for. Kappa light free chains are found in urinalysis. I'll briefly talk about this. Now, urinalysis in patient with multiple myeloma may show increased protein, paraprotein, or abnormal levels of free light chains. And this is known as Benz-Jones proteins in the urine. Light chains are usually filtered across the glomerulus and they are reabsorbed by the proximal tubular cells. In myeloma, this reabsorptive capacity is overwhelmed. Okay. Testing of the serum immunoglobulin level shows an elevated IgG level but low IgA and IgM. So remember, there are 5 main classes of immunoglobulin: immunoglobulin G, A, M, D, and E, all with slightly different functions. So a polyclonal mixture of immunoglobulin is made in a normal immune response to bind foreign antigens such as bacteria and viruses, and these are made from thousands of different plasma cells. However, multiple myeloma, Identical monoclonal immunoglobulins are made by the abnormal cells and other immunoglobulin will be suppressed. So, testing of three most prevalent immunoglobulin classes in the serum usually reveals an elevated um, uh, so there will be elevated abnormal hemoglobin and suppressed residual classes. Immunoglobulin G myeloma occurs in around 50 to 60% of cases. So the skeletal survey, it reveals lytic lesions in the lumbar spine. And I have shown you the photograph of skeletal survey, and you can appreciate the lytic lesions in the skull and then the radius and ulna. So lytic lesions, these have a punched out appearance on X-ray. They can occur anywhere in the skeletal system. And lytic lesions, these are actually caused by activation of osteoclasts due to high levels of rank L or receptor activator of nuclear factor KB ligand. These are produced by pathological plasma cells. So despite the lesions, the serum alkaline phosphatase is usually normal unless there is a pathological fracture. So bone marrow aspiration and trophine demonstrate excess of plasma cells with normal cytogenetic analysis. So normally plasma cells will comprise less than 5% of the cells in the bone marrow. So patient with MGUS or smoldering myeloma may have 5 to 10% plasma cells in the bone marrow. Those with hemoglobin G or hemoglobin A MGUS have a 1% chance of developing myeloma per year and have been shown to have reduced survival compared to controls. Cytogenetics or analysis of chromosome may be predictive of patient outcome. It is used to guide prognosis and treatment choices. Almost all malignant myeloma cells, they will demonstrate aneuploidy more or less than the normal 46th chromosome. Congo red stain is negative. This is very important if you are working up for the multiple myeloma. So amyloid deposition in tissue, it has a particular histological appearance. To confirm the presence of abnormal protein, Congo red stain is added to the tissue and it is viewed under polarized light microscopy. The tissues will have apple green birefringence if positive for amyloid. And finally, NT-pro, BNP and troponin are normal. So testing a troponin level and BNP are easily available tests which can assess with screening for the presence of cardiac amyloid. They should be interpreted in the context of the clinical history and comorbidities. If the troponin or BNP are positive, an echo or preferably a cardiac MRI should be ordered. Okay, so this is all about the investigations of multiple myeloma. Now let's talk a bit about the management. Again, I like to divide the management into immediate management, short term and long term. So first of all, let's talk about the immediate management. So we're going to start IV hydration with normal saline while monitoring fluid status and urine output. Seek advice from the renal team as this patient may need dialysis in the short term. If the hypercalcemia does not respond to fluid, we give a bisphosphonates. Now, some patients with severe renal dysfunction due to myeloma kidney require dialysis in the short term, and a proportion of these will go on to be dialysis dependent. So the renal team will be able to advise on indication for dialysis and conservative options to improve function and prevent complications. Normally, the indication of dialysis include if the patient has persistent fluid overload, if got anuria or oliguria, patient having uremic sign and symptoms, GFR has fallen down to less than 5 ml per minute, patient having respiratory acidosis, hyperkalemia, or hyperphosphatemia. So the IV fluid should be the first step in treatment of hypercalcemia of malignancy, but it may not respond to fluid alone. So care need to be taken in this patient with renal dysfunction, and specialist or pharmacy advice should be sought with regard to dosing and rate of administration. So let's talk about the short-term management. We like to commence the steroids therapy once the investigations are complete. The patient should start chemotherapy as soon as it is available. This patient is a candidate for and should undergo an autologous stem cell transplant. So remember that steroids such as dexamethasone, these are the backbone of treatment for multiple myeloma. So malignant plasma cells are very susceptible to the effects of steroid and can improve hypercalcemia and inflammation around bony tumors very rapidly. First line treatment for untreated myeloma is usually a protease inhibitor based, a combination of subcutaneous bortezomib, oral thalidomide, and oral dexamethasone, and this is usually they are given weekly. Now, those who are very elderly or have significant medical comorbidities such as severe cardiac failure, they will not be able to undergo a stem cell transplant. So, but patients with minimal comorbidities who are well into their 70s may still be eligible for reduced intensity transplant. So autologous stem cell transplant, it is still performed in patients undergoing dialysis. So first steroid, chemotherapy, and then the autologous stem transplant. Common infection prophylaxis and prescribe analgesia for bone pain and offer social work and pastoral care. So all patients on chemotherapy should be prescribed medications to prevent viral, bacterial, and fungal infections depending on the chemotherapy protocol, local risk factors, and patient risk factors. Particular infections were concerned shingles, pneumocystis jirovecii, pneumonia, and fungal lung infection. For those who have significant immunoparesis and recurrent bacterial infection, infusion of IV immunoglobulin may be required, and infections these are need to be treated promptly. So the bony disease has a potential to impact markedly on the quality of life for myeloma patients, like crush fractures and plasmacytomas of the bone can be quite painful. Some respond poorly to first line and traditional analgesics. Radiotherapy should be considered for symptomatic management in those with persistent pain, and consider referral to a pain specialist for the refractory pain. So another important thing is, although the treatments they have improved markedly over the last decade, myeloma remains an incurable condition. So overall median survival is approximately 5 to 7 years with symptomatic disease. The renal dysfunction and with the patient renal dysfunction, it has got more worse prognosis. Multiple myeloma is not a well-known or understood condition among the general population, so education and information is the key. So support should be offered to both parent, patients, and families, including written information about the etiology, symptoms, and treatment of myeloma. So that's all about the short-term treatment. Now we come to the long-term treatment. So the patient prognosis depends partly on renal recovery. Patient may need a maintenance therapy, which may involve a clinical trial. Commence regular bisphosphonate infusion. Consider further stem cell transplant if eligible, and we should consider whether radiotherapy is needed, and monitor regularly for tolerability of treatment and signs of relapse. So I'd like to add few more points. So there are many novel and new agents which are involved in treatment of myeloma. Treatment regimes changes rapidly even over a few years. So enrollment in a clinical trial may be considered upfront at diagnosis or upon relapse post SCT. So a trial may involve treatment with one novel medication or involve potentially synergistic agent combined with standard chemotherapy. Some patients where they may be eligible for second autologous SCT or in rare case an allogenic transplant. So given the median age of the patient and the significant end organ damage that can be associated with myeloma, the majority of patients, they will not be eligible to undergo an allogenic bone transplant due to high treatment related mortality. And radiotherapy is actually used to treat specific areas rather than to control or cure the multiple myeloma. It may be considered in those with symptomatic bony disease, bulky tumors, areas of acute pain, or if there's impending spinal cord compression. So presence of disease, actually it is monitored by serial measurement of the paraproteins, serum light chains, renal function, serum calcium and full blood count. So in those with bony disease, imaging is usually performed after specific treatment or upon diagnosis of relapse. So that's all about the treatment. I think I have discussed in quite detail about the treatment. Thank you very much, and I'll see you in my next presentation.